How long does IV dental sedation last? During procedure, early recovery, residual effects. Fast in, slow out, quick onset, lingering effects. Keep precautions after discharge. 2. Sedation ranges from minimal to general. Dental IV targets moderate or deep, not general. Next, delivery and titration. IV sedation uses titrated boluses or continuous infusion. Dose rate, drug choice, and local anesthesia set overall duration. Sedation lasts as maintained. Orientation returns in minutes. Discharge 30 to 90 minutes. Residual caution up to 24 hours. Examples next. Typical office cases. Extraction, wisdom teeth, full arch. Sedation and observation ranges shown. Next, sedation versus general anesthesia recovery. IV sedation, purposeful response, quick discharge. General anesthesia, unarousable, airway required, longer recovery. Next, pharmacology, timelines, modifiers, evidence. Next, we unpack agents and kinetics, track timelines to discharge, map procedure length, weigh patient and practice modifiers, synthesize evidence. Benzodiazepines give anxiolysis and amnesia, opioids analgesia, propofol rapid hypnosis, ketamine dissociation, dexmedetomidine cooperative sedation. Midazolam acts quickly. Sedation fades sooner than amnesia, with lingering psychomotor effects. Fentanyl follows next. Fentanyl acts fast. Analgesia wanes, but residual risk persists for hours, setting up propofol's rapid titration. Propofol acts fast. Peaking in a minute, wears off quickly. No analgesia. Next, ketamine dissociation. Ketamine preserves airway reflexes and provides strong analgesia. Brief dissociation. Next, dexmedetomidine profile. Cooperative sedation. Dexmedetomidine onset minutes, half-life hours. Recovery smooth, yet prolonged after longer infusions. Synergy discussion next. Combinations change practical duration. Lower doses, shorter infusions, yet respiratory risk persists. Next, context-sensitive half-time trend. Context-sensitive half-time rises as infusions last longer. 3-hour cases often recover slower than 30 minutes. Bolus toggles depth. Infusion smooths, prolonging recovery. Hybrids balance both. Next, onset and stabilization mapping. Expect rapid onset, early titration, with amnesia and analgesia. Next, peak effect and maintenance review. Peak at 3 to 5 minutes. Maintain with small boluses or low-rate infusion. Monitor continuously. After stopping sedatives, redistribution and elimination drop levels. Wake times vary, longer after prolonged infusion. Moderate, often within an hour. Deep up to an hour and a half. We'll cover discharge readiness next. These criteria mark early recovery's endpoint. Discharge aligns with Aldrate, though some effects persist afterward. After discharge, residual drowsiness and slowed coordination can persist for hours. Anterograde amnesia details next. Expect dose-dependent anterograde amnesia for 1 to 3 hours. Next, we'll map durations by procedure. Single-tooth baseline. Procedure 15 to 30, sedation 15 to 45, recovery 30-60. Next, we apply to wisdom teeth soon. For third molar removal with IV sedation, observation precedes discharge. Residual drowsiness lingers. Next, implant placement. 2 to 4 implants, 60 to 120. Sedation maintained. Recovery 45 to 90, longer with higher doses. Full arch next. Full arch runs long, around 4 hours. Sedation extends with wake-up tail, 2-hour recovery. Adjuncts add. Grafting or sinus lifts add operative time, extending sedation maintenance and slightly lengthening early recovery. Age alters pharmacokinetics and recovery. Older, slower, younger, faster. Pediatrics weight-based, variable. Next, body composition. With lipophilic drugs, Adiposity expands volume of distribution and prolongs recovery. Dose to lean mass. Hepatic impairment slows midazolam and fentanyl. Renal dysfunction prolongs metabolite effects. Next, interactions affecting duration. Inhibitors prolong midazolam. Inducers shorten. Other depressants intensify. Chronic use raises tolerance. Details coming up next. Chronic benzo or opioid use raises doses. Alcohol deepens sedation. Recovery lengthens. Next, psychological factor. Anxiety heightens arousal, increasing sedation and perceived duration. Calm with good local shortens. Next, genetic. Genetic polymorphisms alter metabolism, receptor sensitivity, and duration, changing dose needs. Next, targets. Recovery window. Moderate targets. Purposeful responses. Deep targets, pain only, requiring airway support and longer recovery. Reversal next. Flumazenil and naloxone speed wake up, but often outlasted by opioids or sedatives. Monitor recurrence. Next, define risk window. After reversal, antagonists may fade before drugs clear. Rebound sedation can return. Observe 30 to 120 minutes closely. Strong local anesthesia limits nociception, lowering sedative analgesic needs, speeding wake-up with fewer residual effects overall. Plan recovery. Short-acting shortens observation. Longer-acting sustains sedation. Match to case, patient, monitoring. Next, takeaway. IV dental sedation lasts while administered, 30 to 180 minutes. Discharge in 30 to 90. Avoid critical tasks, 24 hours. From onset to residuals, quick start, maintained as needed, rapid orientation, lingering drowsiness. Modifiers next. Duration shifts with case length, dosing, metabolism, shorter with propofol, local anesthesia. Next, case type expectation. Quick snapshot by type. Simpler cases need shorter sedation and recovery. Complex cases take longer. Next, safety checkpoints. Discharge timing hinges on safety checkpoints. Next, we link them to half-lives, CSHT, observation window. Half-lives and propofol offset underpin 30 to 90-minute monitoring, with midazolam amnesia extending early recovery period. Sedation duration individualized by length, depth, drugs, physiology. Longer or higher dose cases prolong recovery. Residual effects persist hours.